My name is Praveen Nara. I'm an event coordinator for CWC and Thai Global. I'm the founder and CEO of Tech.us, a technology company that's focused on artificial intelligence. The topic of this particular webinar is of special interest to me as we have built AI that can identify cancer and can help save thousands of lives. There are millions of people who don't have easy access to good oncologists like we do. And I'm so glad you are on this webinar. Tonight, we have a wonderful panel of experts in the field of cancer. Our guest speakers today are Dr. Sangeeta Agarwal and Dr. Padma Srinivasan. They're both well-established doctors with numerous years of experience. We also have on this webinar two health heroes who are both cancer survivors. Dr. Ramesh Jain, Professor of Information and Computer Sciences, UC Irvine, and Adolfo Velasquez, health hero and a patient advocate. Let me now introduce Dr. Sangeeta Agarwal. Sangeeta Agarwal, MD, is the Assistant Chief of Hematology and Oncology at Santa Clara Valley Medical Center. She is a board-certified hematologist and oncologist and is a member of several organizations, including ASCO, ASH, AMA, and AAPI. She brings over 25 years of experience as a medical doctor. Since 2005, she has been specifically interested in breast cancer and has been involved in clinical studies as well as monitoring residents. She has published several research articles regarding breast cancer and is serving as a clinical investigator for a few ongoing trials regarding lymphoma and breast cancer. Dr. Agarwal is also the Chief Medical Information Officer of Scry Analytics. Scry Analytics uses artificial intelligence to provide end-to-end solutions. Sangeeta is also part of Voice of the Cancer Patients, where she helps empower the patients to take better decisions with insights from over 50 million conversations around the world.
Thank you, Praveen, for inviting me and letting me a part of this amazing organization and this amazing initiative from ICC, Track the Wellness Code. So it is my honor to present and shed some light on the advances in the treatment of cancers that we have achieved over this many years. And I will try to give you basically 1,000 feet bird's eye view of the cancer and the treatments and advances. I apologize for not being able to go into detail of every single aspect of cancer care because of the scope of the topic and the complexity and the details that one could go into. So I'm going to, like I said, talk about the advances in the cancer treatment and the care. And the reason why this is an important topic is actually at this time, pretty much everybody knows somebody who has been diagnosed with cancer and may or may not have the outcome that one expect to have. It is the second leading cause of the deaths in the worldwide, second only to heart disease. So this is the data sheet from WHO. Basically, cancer, there are about 18 million people who are diagnosed with cancer each year. And majority of the cancers are lung cancer, breast cancer, colorectal, prostate, and the stomach cancer. This is a data from CDC actually in 2019. Even though it seems like cancer incidence is going up, but it actually has kind of stabilized in last about 20 years or so. With that, the most exciting part is in last 10 to 20 years, the mortality from cancer is going down, which is very, very, very heartening to see. And so I just want to talk about how did we get here and how we can continue doing better and better in terms of cancer mortality. So the reason behind these progresses are using preventive strategy. Like they say, an ounce of prevention is better than a pound of cure. So if we can prevent the cancers from developing in the first place, that will definitely lead to progress from cancer mortality. The second would be screening and early detection of the cancers that we can actually cure. and then advances in the treatment of cancer that would include surgery and radiation, which I'm not going to go into detail about, chemotherapy, hormonal therapy, immunotherapy, and now the targeted therapies. And also a very important part of the cancer care is improved survivor care. And again, engaging patients so that they can make better and informed decision in their own care, and also empowering the caregivers of these cancer patients. So with that, what are the prevention strategies? So I'm only going to talk about the medical interventions that have been shown to prevent cancer development. I will not talk about the lifestyle changes that lead to prevention of the cancer. So these medical interventions, some of them actually have shown to prevent cancer development. And the most important ones are the prevention of cancer that are infectious associated. So for example, HPV, human papilloma virus, causes cervical cancer in more than 90% of the cervical cancer patients, cervical cancers. It is also known to cause or being associated with head and neck or oral cavity cancers and anal cancer. HPV vaccine became available in 2006, and there was a published trial that showed in 2014 that in women who were vaccinated for HPV vaccine, the incidence of cervical cancer went down by 30%. So again, so HPV vaccine has been shown to prevent cancer development. So I would definitely recommend and giving an HPV vaccine to pretty much all the adolescent boys and girls, because that does prevent cancer. Second one, which has been shown to prevent cancer, is hepatitis B vaccine and also treatment of hepatitis C. Hepatitis, both B and C is being associated with hepatocellular carcinoma, and with advent of hepatitis B, again, there is a drop in hepatocellular carcinoma. We cannot completely eliminate. The other preventable causes of hepatocellular carcinoma is alcohol and NASH, which is fatty liver. And that is a preventable cause with lifestyle changes. Now, what are the prevention strategies for high-risk population? One of them is a very common thing, like use of low-dose aspirin, 81 milligrams. It's been shown to decrease the incidence of colon cancer in high-risk families with Lynch syndrome, or patients who have polyposis found during the regular screening colonoscopy, or family history of familial polyposis. Here, the low-dose aspirin has shown to decrease the colon cancer development by 30 to 40%. In women who have high risk for developing breast cancer, and the high risk is actually calculated by their by a model is known as Gale risk model. It includes family history of breast cancers, some benign breast cancer disorders, the age of the first childbirth, and the age that they started having periods, and age of menopause. So all of these factors are put into this Gale model risk, and we calculate the risk of developing breast cancer in the next 5 years and lifetime development of this. So if the risk is over 1.6 over next 5 years, or lifetime risk is over 20%, these patients actually, in these patients, use of tamoxifen can reduce the risk of development of breast cancer by 50%. And we actually use tamoxifen to identify use tamoxifen to reduce the risk in high-risk breast cancer, high-risk women for breast cancer. Other one is in women who have been diagnosed with a BRCA1 or 2 mutation. Preventive mastectomy, bilateral preventive mastectomy, and removal of the ovaries, called oophorectomy, would reduce the risk for development of breast cancer and ovarian cancer. Next, I will go on to the screening. So the screening is important for the cancers that actually can be cured when they are treated early. Early detection is important for the cancers that can be treated early, and when they are treated early, it can lead to cure. So most important is breast cancer, and we know that early detection and the treatment of breast cancer lead to the cure from the breast cancer, and hence impact the mortality from breast cancer. The other one is colonoscopy for colon cancer. That is a screening modality. Third one would be a pap smear for detection, early detection of cervical cancer, and that would actually lead to earlier interventions and cure from cervical cancer. PSA screening is a bit controversial, but overall, we recommend PSA screening, especially in younger men, or men over 50, to detect prostate cancer early, and again, it can lead to the cure from prostate cancer. And especially people who have been smoking or have at least 10 pack years history of smoking, they are at high risk for developing lung cancer. So in this patient population, low-dose CT scan screening, early low-dose CT scan screening can lead to detection of lung cancer early on, and early intervention can actually lead to cure from these cancers. So these are the ones which are important for screening. Now, going on to the other advances that had led to reduction in the mortality of cancer is our advances in diagnostics. So we know now that with advances in digital mammogram, PET scanning, enhanced MRIs, nuclear medicine scanning can lead to the diagnosis of cancers in much earlier stage. And because of that, we can stage them a lot better, and more precise treatment and can be actually given that would reduce both morbidity, which is the sickness from this cancer, as well as mortality. With these, there are new techniques developed in terms of surgery. Minimal invasive surgery is available to treat many of the cancers now. And advances in radiation therapy actually also have led to much better control of cancers. Both surgery and radiations are local treatment, and I'm not going to talk anything more about it. But then there are many advances has happened in systemic therapy, which would apply to early treatment as well as late stages treatment. And again, advances in these therapeutic modalities also have led to improvement in mortality or deaths from the cancer. So talking about chemotherapy, this is the oldest form of therapy. It is a systemic therapy. That means it actually treats the entire body as opposed to surgery and radiation. So what are chemotherapeutics? So these are the drugs that actually would kill the cancer cell, kill all the cells by attacking the DNA of the cells. So these drugs would kill both cancer cells and normal cells. The property of these cells, that normal cells actually have their DNA repair mechanism intact, and the cancer cells actually have impaired DNA repair mechanism, is what we use to actually use these drugs to treat cancer. So when we give chemotherapy, it would kill both cells, but the cancer cells cannot recover from chemotherapy, and normal cells can. And that's why the chemotherapy is given in cycles to give normal cells to recover in between the chemotherapy cycles. In practice, we use a combination of various chemotherapy, and the rationale is to use the chemotherapy which have different mode of actions, so that we can synergize their effect, but also reduce the toxicity of the normal cells. And the first example of the combination chemotherapy that actually cured a cancer was in 1965. The treatment regimen called MOPP cured patients with Hodgkin's disease. And to this date, chemotherapy still remains the mainstay of the cancer treatment. Moving on, from chemotherapy to, I go back to just basically again highlight the advances in chemotherapy in the last about 20 or so years. We have developed chemotherapies that are now safer and less toxic, as well as also develop measures to actually take care of the toxicity that that has enabled us to give chemotherapy to many more patients and see the effect. We also have become smarter and developed molecular techniques that actually have enabled us to identify people who will benefit from giving chemotherapy. In early 2000s, we also learned that even early cancer patients may benefit from chemotherapy, such as in lung cancers and colon cancer, something called adjuvant chemotherapy, which we give after surgery to possibly kill any circulating cells, and that actually prevents cancer from coming back. Again, in 2004, a biomarker such as Oncotype DX was developed to figure out which patients will benefit from chemotherapy and which patients can be spared from chemotherapy in breast cancer. And that's how we can actually identify precise patients who will benefit. Later on, we also figured out how to de-escalate. I mean, the tumor types which probably can be treated with less chemo, and also figure out the ones that require higher doses of chemo to overall actually increase the impact of the therapy on these cancers. So chemotherapy is one modality. Now moving on to targeted therapy. So cancer is actually a genetic disease. So all of the cancers are developed because of some abnormality in their cell cycle pathway, which leads to uncontrolled growth, or mutations that also lead to development of cancers. So if we can identify and develop the therapies that would target all these driver mutations or driver abnormality that is driving the cancer cells, we can actually achieve much better responses than generally giving chemotherapy, and sometimes even can combine those treatments. So some of the examples are monoclonal antibodies. So antibodies are produced in the body to kill bacteria and other infections. And these antibodies are specific to a particular protein that could be either found on the bacteria or infection or on a cell surface. So monoclonal antibodies are actually cultured or made outside, and they identify a specific protein on a cancer cells to mark it. And when they are infused, they use the body's immune system to kill those cancer cells. And the examples are rituximab or Rituxan, that actually has revolutionized the treatment of non-Hodgkin's lymphoma. We all know about Herceptin, which is specific for HER2 positive breast cancer, and literally revolutionized the treatment for breast cancer. And since then, many, many more monoclonal antibodies actually have been developed for the cancer treatment. The other type of targeted therapy is something we call small molecule inhibitors. So these are the drugs that actually target some growth pathways inside the cell. By binding to those growth pathway enzymes, they can block the cell growth or cancer cell growth. And the poster child for this small molecule inhibitor is imatinib or Gleevec, that was discovered or came in practice in 2001, and basically changed the whole landscape of chronic myelogenous leukemia. The leukemia, CML, used to be universally fatal, and actually now people live decades with imatinib and some second generation small molecule inhibitors. The other area is epidermal growth factor inhibitor for lung cancer, which has completely changed the lung cancer treatment in patients who have these mutation in epidermal growth factors. And the other one is sunitinib, which is another tyrosine kinase inhibitor or small molecule inhibitor used to treat kidney cancer and now many other cancers. And the third type of targeted therapy is we call this antibody drug conjugate. So this is an engineered molecule that combines both monoclonal antibody and combines it to a chemotherapy. So usually this chemotherapy is a very potent and toxic chemotherapy, which many times the body is not able to tolerate if it is given in high doses. So when this combination is used, the antibody recognizes the cancer cells and then releases this chemotherapeutic drug near those cancer cells. That way, it reduces the toxicity and deliver and increases the efficacy. And one of the examples of this targeted therapy is called TDM1 or Gedcyla, which is used in HER2-positive breast cancer. So just to give you the progress here in the chart, in 1997, the first monoclonal antibody, Rituxan, was utilized to treat non-Hodgkin's lymphoma. And then Herceptin came into the picture. And in 2001, the imatinib came. And since then, actually, there are, I would say, not 100 plus, but probably more than close to about 500 new FDA-approved targeted therapies are actually now available for the cancer treatment. And this is just a cartoon to show you that there are so many targets that could be actually identified and could be drugged or modified by using, various drugs. Not all the targets are being targeted right now, but a potential area of research and drug development. Now coming to immunotherapy, which is probably the hardest topic right now in cancer treatment. And this utilizes basically body's own immune system to kill the cancer cells. So what happens in cancer, so it basically uses the T cells to recognize cancer cells. Generally, T cells are considered immune they're involved in the immune surveillance. So these are the ones that are involved in finding out viral infections, figuring out if there is a foreign protein inside the body and taking care of it, or kill the cell which is looking abnormal and not going to be surviving or performing the function, called this apoptosis. So the way that tumor cells evade recognition from the T cells is it actually, going back, T cells actually could be stimulated, and when it's stimulated, it recruits the immune machinery of the body to kill that particular type of cells. So it has some immune stimulating factors and some receptors which actually disable the T cells or inhibit the T cell activity. So some tumor cells actually have produces a marker or protein called PD ligand. PD ligand, when it binds with the PD-1 receptors on the T cell, it actually camouflages itself, and the T cell cannot recognize it as a foreign or abnormal cell. So with this discovery, we have created an antibody that binds with the PD-1 receptor on the T cell. Now, when that PD-1 receptor on the T cell is bound, the tumor cell now becomes recognizable by the immune system, and now the T cells can actually recruit the immune system to kill the cancer cells. And we know that body's immune system is probably the most potent way of dealing with or killing the cells that do not belong in the body. So now the multiple PD-1 inhibitors actually are available in the treatment. And I'm quickly going to show the progress. So now the multiple immunotherapies are actually in the market or being used, and many more tumors can be targeted by the immunotherapy. So moving on from here, I would go to a very other important aspect of cancer care is in survivor care and patient engagement. And to basically take care of the people who have survived and having them improve their overall lifestyle. And also a very important part is including patient and engaging them into making their own decision about their treatment and their options. I'm just going to go over an initiative that I have taken along with this is in the partnership with a company called Sky Analytics. And this platform is called voiceofcancerpatients.com. Here we collect messages from all the available forums from many different cancers and put them on one single platform, so that if somebody wants to actually find out what other people are talking about, they don't have to find a forum. They can go and ask a question, and it pull out messages from all different forums into one on single page. And it also gives an aggregate of what people are talking about, common side effects, and what they can do to actually help with this help with those side effects. And then if somebody likes that message, they can actually go to that link, and this platform will allow them to go to the original forum. So this also has a community of patients. And then we also do analysis of all the patients concerned and publish the articles about what people are talking about, what are their concerns. So it provides this education as well as in the data about what people are talking about various cancers. So with that, I would like to close that it requires everybody to work together, because if one has to go fast, you go alone. But when we have to go far, we have to go together. And with that, I close, and I'm happy to answer any questions.
Thank you, Sangeeta. Definitely. And I love that picture. It's so beautiful. I want to go there. With that, let me introduce you to Padma, Dr. Padma Srinivasan. Dr. Srinivasan is a nephrologist in Oakland, California, and is affiliated with multiple hospitals in the area. She has over 48 years of experience in the medical field. With that, Dr. Srinivasan, thank you so much for joining.
I'm going to talk about how our lifestyle choices impact our risk of getting cancer and how we can make better choices to mitigate those risks. Cancer, as Sangeeta said, is not only the second leading cause of death in the world, but also in United States. And as she pointed out, we have greater number of people with cancer, but also more improved treatment. So a lot of people are living with cancer, and we can see how we can reduce our risk even further. The CDC has stated that overweight and being obese and overweight makes up to 40% of cancers that are diagnosed in US. That's a huge number. Up to 40% is attributed to being overweight or obese. Most of these cancers are in the abdomen, as you can see: colorectal, stomach, pancreas, liver, ovary, kidneys, etc. The breast cancer, esophagus, and thyroid cancer. Obesity is a risk factor for cancer, as we saw. What are the other risk factors? Consumption of sugar and white flour. And our consumption has increased a great deal in the last several decades. Cancer cells are avid for glucose and makes them grow. And along with sugar, we have increased insulin and insulin-like hormone, which is another inflammatory hormone, and they make cancer cells proliferate. We also have a huge number of environmental chemicals, many of them toxins, more than 80,000, and only a few have been analyzed. We use more than 5 billion tons of pesticides on our crops and lawns and insects, etc. The CDC regularly reports on human exposure to environmental chemicals, and it found that each of us in America has, on an average, a body burden of 29 chemicals. So what are some of these environmental toxins, and what do they do to us? Heterocyclic amines, these are produced when you grill meat at high heat, that is over 300 degrees Fahrenheit. And whether you grill them or barbecue them or pan fry them. And these heterocyclic amines, they damage the DNA and are associated with breast, colon, and pancreatic cancer. Dioxin and DDT are not used. They are banned in US now, but DDT is still used worldwide for malaria control. Both of these are classified as class 1 carcinogens, and both are associated with breast cancer, and DDT also with endometrial cancer. Many toxins accumulate in fat. As I showed you in the diagram, many of them are in the abdomen or like the breast surrounded by fat. Many of these toxins accumulate in fat. The cancers that are increasing incidence are those that are surrounded by fat. Another variety of environmental toxins are of more personal use. These are things that we use at home, and they are endocrine disruptors. That means they act like our hormones, or they disrupt the hormones in our body, and they are also called xenoestrogens because they act like the hormone estrogen in us. Bisphenol A is a very common one, and it was taken out of baby bottles, but it's still used in plastics, in food packaging, and CDC has found bisphenol A in the urine of over 93% of Americans who were tested. Phthalates is in perfumes, in fragrant candles, in medication coatings, and food packagings. Parabens is a huge class that's a preservative in foods and sodas and medications and lotions that we put on our skin. And our skin is our largest organ. And if we put lotions that have parabens, we are absorbing them. So how does cancer happen? So due to insults and accumulated toxins, the cell mutates, it becomes a cancer cell. Once it becomes a cancer cell, it is now immortal because it keeps on dividing, and there's no programmed cell death, which is called apoptosis. So it doesn't have apoptosis or cell death. It also creates its own blood supply. So to nourish it and keep on growing, it needs blood supply, and it's called angiogenesis. And to keep it growing, it creates inflammation, and inflammation brings it more nutrition and more cells and makes it grow faster. So each one of these steps we can stop or reduce by our lifestyle, and we'll see how. Cancer is a disease of Western lifestyle or the wealthy. The principal difference between populations with the highest and the lowest rates of cancer is what they eat, is their food. The risk of breast and colon cancer can be halved by just decreasing the meat intake. This is per the Environmental Working Group. You can go to ewg.org and look at their website for the Dirty Dozen. Dirty Dozen is the list of fruits and vegetables that have the highest residues of pesticides. Then you can buy organic for those. What are the best cuisines? Well, everybody knows about Mediterranean cuisine. It's good for diabetes. It's good for heart disease. It's also good for cancer because it incorporates lots of fruits and vegetables and whole grains, and olive oil, which has a lot of bioactive polyphenols. How about Indian diet? Indian diet actually can be very, very good because we have excellent spices that have anti-cancer activities. We have dal or lentils that have fiber, which feed the good microbiome in our gut. And it also has many beneficial polyphenols. However, we should then avoid pakoras and samosas and gulab jamuns, and also high glycemic foods like white rice, and choose a lower variety glycemic rice like basmati rice. So there was a study, very large study done by Loma Linda University that was called Adventist Study 2, Health Study 2. And this compared the food habits of the Seventh-day Adventists. So when compared to non-vegetarians, the lacto-ovo vegetarians had less gastrointestinal cancer, that is stomach, colon, pancreas, etc., esophagus. But the vegans who didn't eat any animal protein had the overall lower incidence of cancer and female type cancers. So this is a slide of how, at what spots different anti-cancer foods act. If you look at cruciferous foods, which we will talk about later, they act against multiple steps in the genesis and progression of cancer. It detoxifies the toxins. It causes cancer cell death to commit suicide. It prevents their blood supply. If you take green tea, it does the same. If you take citrus fruits are the commonest fruits eaten worldwide. You have pomelos, tangerines, oranges, lemons, etc. So citrus fruits act at every step. Turmeric is powerfully anti-inflammatory and also has other actions. So some specific cancer foods, anti-cancer foods, mushrooms. Mushrooms have what is called aromatase inhibitors, which is actually used for treatment of breast cancer. It slows and stops cancer cell growth, increases the immune cell activity, and mushrooms are shown to protect against breast cancer. Berries, ellagic acid is in raspberries and strawberries. It blocks angiogenesis, it is an antioxidant, and it also prevents genetic mutation. Ellagic acid is also found in walnuts and pomegranates. We talked about the berries and citric fruits. However, pomegranates are top-notch fruits, also have multiple anti-cancer activities. And it's also in all systems of traditional medicine, from Ayurveda to Middle East to Native Americans, etc. Blueberries, 1 cup a week significantly decreases the risk of breast cancer. Just 1 cup a week. When fresh berries are not available, frozen is okay. I'm going to mention amla, Indian gooseberry, because it's in our tradition and our system of medicine. The amla is mentioned in Ayurvedic text before 400 BC. So we know how to use it. We know it's not toxic. It is in lab tests now in the US, and it's found to be active against triple negative breast cancer and lung cancer, but it's in very early stage of testing. But you can eat it as food. Cruciferous vegetables is a very large category of vegetables, so I will just name some: broccoli, Brussels sprouts, bok choy, cauliflower, cabbage, kohlrabi, kale, Swiss chard, radish. So you can have a couple every day, and they have the bioactive polyphenols, which are sulfur compounds, sulforaphanes and indole carbinols. There's an inverse relationship between how much cruciferous vegetables you consume and the risk of several cancers: breast, colon, ovary, stomach, prostate, etc. Tomatoes have lycopenes, and they stop blood vessel cancer cells from growing their blood vessel. The skin has 3 to 5 times the amount that's in the flesh. And this is true of most fruits and vegetables. The skin and the outer layers have more polyphenols, so don't peel if you can. 2 to 3 cups per week gives you a 30% decreased risk of prostate cancer. So another fruit, wonderful fruit category. This was a very large study of almost 500,000 people done by NIH, and was a prospective population-based study. 2 stone fruits daily, stone fruits being cherry, nectarine, peaches, plums. 2 stone fruits a day, or apple, you could have apples, decreased the risk of squamous cell esophageal cancer by 67%. So apples, what type of apples? Granny Smith and Red Delicious. Now nuts. Nuts are super because they have anti-angiogenic effects. They also have omega-3, which is anti-inflammatory, and boost immunity. There was a Harvard study done of patients who had stage 3 colon cancer. And after their surgery, when they were eating normal diet, they were started on a serving of nuts twice a week. And it showed, after 6 years of follow-up, those that were on the nut supplements, they had a decreased risk of death by 47% and increased disease-free survival of 55%. So incorporate some nuts into your diet. Okay, spices. Our diet is great because we have so many spices. I'll just touch on 2. Turmeric. Turmeric is now actually in clinical studies in the US. It has multiple effects against cancer. It has been shown in the lab to be effective against multiple cancers like brain cancer, stomach, prostate, ovary, lung, etc. and it's part of our food. So have it as your food. Ginger is also excellent because a study in University of Michigan showed that if you dripped ginger extract onto ovarian cancer cells, those cells committed suicide. The other thing is when people who were at high risk for colon cancer, these were people with high risk for colon cancer, given ginger daily, and after a while they had their colonoscopy done, there was less proliferation of colon cells. So this is again our food. Put ginger in your tea or in your food. So the last vegetable I'm going to touch on is garlic, the family, garlic, onions, leeks, etc. It has been shown that higher intake of garlic and onions, there's a lower incidence of gastrointestinal cancer. Iowa Woman study was a large study comprising of postmenopausal women who were followed for 22 years. And what they found was there was a strong inverse relationship between garlic consumption and colon cancer risk. High intake of garlic is also associated with a reduction in the incidence of prostate cancer, breast and pancreatic cancer. Now we come to exercise. This is another key part of health strategy. When you exercise, you actually decrease your fat tissue, which is the repository of the environmental toxins. It decreases the blood glucose, and so insulin and IGF-1, which cause cancer cells to proliferate. You decrease your stress hormones and increase your feel-good endorphins. You decrease your blood inflammatory cytokines or inflammation, and you increase your immune cells. So this has been shown in large studies that people who exercise have less incidence of cancer and also fewer relapses. Most cancer patients have fatigue, and sometimes it's persistent. And cancer patients after chemotherapy also complain of brain fog. It's this feeling of floating. And it has been objectively studied also. And it really comprises of difficulty in recall, memory, focusing and attention, higher executive function, and multitasking. And it can be really disabling and depressing. In a third of patients, it can persist for a long time. So what helps? Exercise can help improve this. So please do exercise every day. Stress. Cancer is both an acute stress and persistent chronic stress with elevations of cortisol and norepinephrine. There's a feeling of despair. And this inflammatory hormones, they depress our immunity and disable our natural killer cells. What are natural killer cells? They are our white blood cells that are first line responders. When they see the cancer cell or a virus, they will kill them. So how do we relieve our stress and improve our immunity? There was a study done about on mind-based stress reduction, also known as mindfulness meditation. So participants who did 8 weeks of mindful meditation, they then had the flu vaccine, and it was found that those that did the meditation had a bigger rise in the antibody response, had a bigger, more brisk antibody response, showing that they had better immunity. After 16 weeks of mind-based stress reduction, there was also an increase in telomerase enzyme. And the telomerase enzyme is what maintains the telomeres at the end of chromosomes, and it's a measure of cellular vitality and aging. Stress. So how else can we combat stress? One way is by meditating. The other way is by stimulating vagus nerve, which also meditation does. So when we stimulate the vagus nerve, we activate our autonomic nervous system, the parasympathetic system, which is the rest and digest system. So when we are rested and relaxed, what happens? our blood glucose goes down, our inflammatory markers goes down. We are less in risk of heart disease, and all-cause mortality goes down. So it is good to have a good vagus tone. And how do we do that? One is by meditation, and the other is by doing slow, deep abdominal breaths, pranayama. It has been shown by study in South Carolina that those people who do even short-term deep breathing, pranayama, their inflammatory markers go down. Another way of stimulating the vagus nerve is social connectedness. It improves the vagal tone. A 20-year study of women with breast cancer, both in US and in China, showed those that had better social support had better survival. So if you know somebody who has cancer, or if you're treating somebody who has cancer, you have to pay attention to their psychological well-being and not just their physical well-being, because they both are connected. Yoga has been shown to decrease anxiety and decrease the cortisol level. So daily yoga practitioners also have decreased total response that show that and improved pain sensation. So they can tolerate pain better and are less anxious. So putting it all together in summary, so our lifestyle encompasses how we keep our environment as much as possible free from toxins, how we make our food choices, make good anti-inflammatory, anti-cancer food choices that we went through, and avoid inflammatory foods, have a healthy psychology that consists of deep breathing, meditation, social connection, and humming. I forgot to mention, singing and humming and chanting, they activate the vagus nerve around your throat and your voice box, and that can activate your vagus nerve. So sing and chant, and Om chanting can do that too. And lastly, take care of your body, lose weight, and exercise every day. And if you put it all together, you will construct in yourself a very hostile environment to cancer. So thank you for listening.
Thank you, Dr. Padma Srinivasan. Excellent presentation. It's so informative. Things that we do on a regular basis but don't take seriously can have a huge impact on our cancer based on your presentation. So, and it's good to know that our Indian foods naturally have a lot of cancer protective features, if I can call that. Thank you for that. So I have several questions. We do have two health heroes that we'll be bringing in just a few minutes. But in the meantime, I want to start asking a few questions, and then we will move on to health heroes. The first question is from an anonymous attendee. Does soy cause breast cancer?
So there is no evidence that soy causes breast cancer. The only reason why it was actually even suggested is soy sometimes contained phytoestrogens, and estrogen replacement in postmenopausal women was connected with development of breast cancer. But the amount of soy that is needed to actually cause breast cancer is very, very high. So I would take this notion out. There is no evidence that the regular amount of soy causes breast cancer.
I would just suggest, add to that don't take soy supplements. They are sold, but do not take soy supplements. Soy per se, if you take it as tofu or soy milk, actually is such a weak estrogen that they block the natural estrogens from acting. It can be protective. But yeah, talk to your oncologist first.
Yes, yeah. I would caution against the supplements, because sometimes they are very concentrated amount of these active ingredients. So that can cause cancer, but regular amount of soy, tofu, soy milk does not.
Got it. The next question is from Rajni. What's the difference between CT scan and PET scan?
So, they both are scans. So CT scan is basically radiographs of the body. We give a contrast, and CT scan takes the pictures. PET scan is an active scan. So that is done by giving a radioactive glucose, And the whole idea is the cells that are dividing, which are cancer cells, and sometimes very, very high inflammatory cells, can pick up that glucose. And because it is radioactive glucose, when it is scanned, it shows up that areas of active cancers, they're called hot areas. So then those scans are superimposed on the on the CT scan, and we can identify, okay, this heat is coming from the muscle, this part of the bone, and there is a breast. So I would say PET scan is an active scan, and CT scan is basically the pictures of the body. Basically.
Got it. And next question is from an anonymous user. Mastectomy and removal of ovaries, do they just reduce the risk of specific cancer, or do they completely eliminate it? And there's a continuation of that. If the ovaries are removed, how can someone get ovarian cancer? Likewise, the same question for mastectomy.
Yeah. So removal of the breast basically eliminates the cancer up to 90+%. There is always a chance that the breast cancer can develop on the skin of the chest wall or underarms. So there is a very, very small chance that one could develop it. But, removal of the breast will over 90% chance that you would not get a breast cancer. Similarly, in ovaries, removal of the ovaries eliminate the ovarian cancer, but there is also very, very small chance that one could develop a peritoneal cancer, which could be of ovarian origin. So you are eliminating the risk by more than 95%.
Got it. And this question is from Dawal. What's the reason for lung cancer in people who have never ever smoked?
So smoking is only one of the risk factors for lung cancer that we know. Many other risk factors are unknown. And so much emphasis is made upon smoking because the smoking was a leading cause of cancer in early 90s. And as people, as the education campaign started against smoking, in fact, the smoking associated lung cancers have come down significantly. And if you remember the slide that I showed you, where there was a blip upwards in the incidence of cancer, and then over time there was a blip downwards, that was due to elimination of smoking. So it's just one risk factor. There are others that we don't understand, and we don't know what causes most of the lung cancer or most of the other cancers.
Yeah, totally. I came to US about 22 years ago, and so many people used to go outside the office and smoke. It used to be like a social thing, and it has significantly gone down since then. So totally. And thank you, doctors, for your answering the questions. I'm going to bring on health heroes and let them speak for a few minutes, and then we'll come back to the questions. First, I'm going to bring Professor Ramesh Jain. Ramesh is a wellness patron and a distinguished professor at the Computer Sciences Department in UC Irvine. He is an innovator and a serial entrepreneur who is currently working on preventive care devices with analytics for diabetes. Health and wellness come naturally to him as he himself being a cancer survivor and health hero. He also applies evidence-based lifestyle practices in his daily life. Ramesh has been an active researcher in computer vision, artificial intelligence, and digital health. Back in 1987, when artificial intelligence was still not popular, he founded and directed Artificial Intelligence Laboratory in University of Michigan. At UC San Diego, he founded Visual Computing Lab in 1995. You can tell how much experience he has. And then at UC Irvine, he is the founding director of UCI Institute for Future Health. Ramesh is the recipient of several awards, including the ACM SIGMM Technical Achievement Award in 2010. He's going to share with us his life journey and what he is doing. With that, Ramesh, welcome.
Thank you very much, Praveen. Thanks a lot for your kind words. I got involved with ICC CWC about a year ago. And in this year, it has been a very rewarding experience to me because I got to hear so many experiences, so many things, and I'm learning a lot. For example, today was really remarkable. Hearing from Dr. Sangeeta Agarwal and Dr. Padma Srinivasan about what cancer is, how it happens, what kind of treatments are there, and also hearing from Dr. Padma Srinivasan about how lifestyle affects. So let me share with you some of my experiences. I'm not a medical doctor. I don't understand uh, much about biology. In fact, till uh, about 15 years ago, I was not even much interested in that. But then life is interesting. Sometimes you have some transformational experiences. Uh, my life was going smoothly. Suddenly in 2004, in January, I was told I have gastroesophageal cancer. The news came from almost nowhere. And when I was listening to Dr. Agarwal, it was very interesting to hear the types of treatments because, except for treatments that became popular in the last 15 years, I had the privilege to experience all these things. I went through chemo, I went through good amount of radiation, and I went through surgery. So this experience was really transformational. I went through these things. I'm showing you how life can transform in just 3 months. I went through cancer treatment, going through all these things to my daughter's wedding in just 3 months. And my daughter's wedding was remarkable for two reasons. Number one, it was so close to my cancer. Uh, I realize the importance of family. Sometimes I tell people, and this is not a joke, this is very serious, that getting cancer was life changing for me. I learned about life more during those 5 6 months when I was going through cancer treatment than any time before that in my life. And after that, I'm continuously learning. And this particular picture that I am showing you is very important for one other reason. Number one, Adolfo, who is going to come, Adolfo Velasquez is going to talk about his experience after this. But I have Adolfo in my family. Adolfo Juarez married my daughter Smriti. And here next to that is my wife, Sudha, who turned out to be Sudha in my life because we had been together for almost 50 years. And she went through cancer as much as I went through. But the important thing is that the biggest thing that I learned during that treatment was because of my very close friendship that I developed with my surgeon and with my oncologist. In fact, I promised them that after I leave, I used to joke that if you cure me, then I'm going to change completely my research focus. And they used, because I used to give them difficult time that in medical science they don't use the advanced technology except for diagnostics, and that they don't understand how particular diseases and cure work because they don't have enough data. So Dr. Brunson, who became very close friend, used to say, Ramesh, you have been dealing all your life with data, go and do something. So I told them that if you cure me, that's what I'm going to do. I'm going to change my research completely. And he used to say that we detected your cancer so early that we are going to cure you. So I promised them that if I get out of hospital, I'm going to do something about it. So when I started studying this, boy, Dr. Padma Srinivasan, the way that she articulated was wonderful, wonderful for setting up my talk. World Health Organization shows that 70% of our health depends on our lifestyle and environment. Of the remaining 30%, only 10% depends on medical health care. 20% depends on genetics, and because of environment and lifestyle's effect on genetics through epigenetics, we can safely say that more than 3/4 of our health depends on our lifestyle and environment. Until recently, there was no way to measure lifestyle. And as you know, if you can't measure a thing, you can't control and you can improve that. So let's look at the effect of this. This is what really happens. What makes us healthy is this here: 10% medicine, 20% genetics, and this is 70% lifestyle. Now, would you see where we spend our money? All the elections in the United States are always about healthcare. And COVID has taught us the importance of health and lifestyle. But look at this. We spend 88% of our money on 10% that improves our health. And we spend only 4% that results in 50% improvement on this. This is mind boggling. We got to do something about this. So my research started changing and I started thinking about this. And it was very good that I ran into Dr. Howard Fedroff, who was Vice Chancellor for Health at UCI. And we started interacting and having lots of coffee together. And during this, we realized that the future health is going to be very different. It's going to be determined a lot more by data, because using all the new devices, now we can measure our lifestyle, we can measure our environment, we can understand exactly what's going on with us. We can wear these things, we can use these things, and we can even wear these things. All these things are giving us enough information so that we can start guiding principles for future health. And as you heard just very few minutes ago, depending on what we eat, how we spend our lifestyle, we find out that each person is going to become unique. It's genetics, but environment and personalization. The second thing that we find out is you should not get treatment only when you are sick. You got to take care of yourself every moment of life. Yeah. That means you have to find a way that your doctor is always with you. And with these ideas, we founded here at UCI an Institute for Future Health. I'm the founding director of that. We have 40 faculty members from 10 departments, including medicine, nursing, public health, business, and every possible department is participating in this. And the thing that we want to do in this is really my dream. I want to build a personal health navigator. All of us who are living now have realized in last 10 years how easy it is to go to any place. All that you do is tell your phone or tell your navigation system where you want to go. All the knowledge about the maps and roads and how bad is the traffic or how good is the traffic and all kind of things are available in the navigation system. All that the system keeps on doing is at the right time, at the right place, it tells you, hey, in 100 yards, you will have to turn left. And things like that. Can we do that for our health? That's what you want to do. That means our goal is, can we develop a navigation system that will guide us for better health? Can we do this so that it uses all real-time information? That means by measuring my biomarkers, by considering measuring my environment, by measuring what activities I am performing, what kind of things I am doing, can it provide me right information at the right time to take correct action, whether it is related to stress, whether it is related to sleep, whether it is related to activities, and most importantly, whether it's related to food. Food is more than 50% part of our lifestyle. So can we do this? Also, can we make this so that this kind of health state can be determined and guided to for anybody, whether you are a very rich person, whether you live in a remote place, whether you live in India, whether you live in San Francisco, or wherever you live, based on your mobile phone and now these wearable devices that are becoming inexpensive almost every day, you should be able to do this. And this is what all our research is taking us. And that's what we are trying to develop as a system that will help you every minute to guide your life. The first experiment we are doing is related to diabetes. There is a company called Dianavi that has been formed by a diabetes expert and myself and some more friends. We have already released our first version of the product on iPhone that you can do it. It basically is a diabetes coach for you. It is always measuring based on your iWatch and based on your phone and based on any other sensor that you have, all this kind of information. It's getting all this information from different types of devices, combining these things to convert this to your progress in terms of activity, sleep, monitors your glucose, nutrition. It also monitors what kind of medication you are supposed to take and are you taking that medication or not. It provides all these things in terms of not only the numbers that you don't understand, but actionable insights. It provides you guidance of how you can convert it, or at what place and what time you normally tend to eat bad food, or at what place what kind of activity results you in more stress. It is building your own model. So every person is unique. We are building that person's model and we are providing guidance to the person. So your phone becomes your doctor who is always with you. Thank you very much.
Okay.
This is what we are trying to do.
Perfect. Thank you so much. That's really amazing. Thank you for sharing your life story. As much as we learn from all the experts and books and many other media, when we really learn another person whom we can connect with, who has gone through it and recovered and is living, it's been 16 years since you got cancer, and you look as healthy as a 75-year-old can be. So congratulations and thank you for sharing your story.
My pleasure.
So with that, I would love to invite Adolfo Velasquez. He has a Master's of Science degree in counseling and currently is the chair and academic counselor of a California statewide counseling program, EOPS, Extended Opportunity Program and Services at City College of San Francisco, serving low-income, underserved, and disadvantaged students. More importantly, Adolfo is a 10-year cancer survivor and a warrior. Adolfo is going to share his cancer story with us now.
Okay. Thank you, Praveen. Good evening, everybody. As he mentioned, my name is Adolfo Velasquez. And yes, I am going on my 10th year of stage 4 kidney cancer. So it all began back in 2011. Soon after my birthday in January, I thought I was passing kidney stones. Went to the doctors and they found I did pass something, but they also found microscopic blood in my test. 2 weeks later, I get the call from the urologist. They had me retest, and they did a CT scan, and they found I had a big tumor, 12.1 centimeter tumor, larger than what they commonly see. And they said, okay, our only choice here is to remove it. So in 2 weeks, February 22nd of 2011, I had surgery, removed my kidney. At the same time, they found that I had several nodules in my lungs. So after surgery, I had to wait a few months to take another CT scan. And at that point, in May of 2011, they found that the nodules had grown. What it showed is that the kidney cancer had metastasized to the lungs. That put me at stage 4. So from the very beginning, I was stage 4. And I've been there ever since. But, part of it, when I was initially diagnosed, I asked myself, why me? I didn't fit any of the categories. I didn't fit into. I wasn't overweight. I wasn't obese. I ate well. I exercised. But the one thing that was prevalent at the time, which is now shown to increase the cortisol, which is increases inflammation. I was highly stressed at the time. My father had just passed away 6 months before I was diagnosed. I was the main caretaker. I was working 3 jobs, family. I was doing it all. The Superman syndrome. So naturally, again, that's the only thing I can attribute it that really increased the cancer. So with that, after the diagnosis, I began what Dr. Sangeeta talked about, targeted therapy. Luckily, because kidney cancer did not take well with chemotherapy, I never did the traditional chemotherapy. The targeted therapy had just come out a few years prior to my diagnosis. I started with the sunitinib, which goes by the brand name Sutent. I did that for 3 years, and that largely reduced the majority of the nodules that I had in my lungs, with the exception of one in my right lung that I had. However, I found out that when they defined what several nodules were, I had over 15, 16 nodules in my lungs. So the targeted therapy really worked. However, targeted therapy does have, it works for a certain amount of time. So I was on the Sutent for 3 years. In 2014, I switched over when the Sutent stopped working because the mass that I had in my right lung started to increase. At the same time, one of the nodules in my left lung started to increase. I did have my second surgery in 2014 on September 4th to remove that mass from the lung. And I continue on the Inleta. And I should mention also, which I'll talk about at the end more, but everything that I do in combination with the treatments is that in 2011, I also went to Cuba and started a homeopathic medicine that they have that supplements and complements Western medicine, whichever type you're taking. So I've been taking that all along since 2011. Back to 2014 surgery. I started on the second phase of targeted therapy called Inleta, which again helped. It reduced the nodules that I had, kept that at bay. However, that too ran its course, right? At that time, immunotherapy had not been approved for kidney cancer, and it was only approved for melanoma, which was the first one that it worked on. However, at the time when my second round of targeted therapy stopped working, immunotherapy had been approved. So I kept questioning my doctor, my oncologist, about immunotherapy because I had read up on it. It was something I did as a self-advocate for myself. I always researched, and we started immunotherapy. And within a year, all the nodules in my lungs had disappeared, which were 2 main ones. And I went on immunotherapy for less than a year. In 2017, I finished. We stopped because there was no growth. There was no evidence of cancer. And I have not gone back on immunotherapy since then. My lungs are still clear in the pelvis, but cancer being what it is, it's tricky, it's complicated. Last year, 2019, I was diagnosed with a mass in my brain, frontal lobe. And it turned out to be an offshoot of the kidney cancer. So despite the fact that I didn't have, and I still have no evidence of cancer in my lungs or pelvis area, it had metastasized to the brain. So last year when they diagnosed that was on May 4th of last year, 2019. They put me on anti-seizure pills. They put me on steroids, which had a really serious effect on me. They put me on aspirin because they weren't quite sure what it was. But after a CT and then an MRI, it confirmed that it was a mass in my brain, in the frontal lobe. So on August 20th, first I tried radiation, and that didn't quite, it worked some, but as I tried to wean off radiation, the symptoms would pop up again, which the main symptom that started the whole diagnosis was I thought I had spasms in my right arm, but it turned out to be seizures. So the surgery, August 20th, right? I had that, it was successful. But I did have to go to rehab because it did affect the right side of my body, which was already, I felt it before surgery. So they sent me to rehab. I went there for 2 weeks from August 23rd to September 4th. The day I got released from rehab, I started developing pain that day. So that same evening that I got released I went back to the emergency September 4th in the evening and spent another 2 weeks. I had developed blood clots, they found. And I had a very severe kind. It's called saddle pulmonary embolism, where I had blood clots covering both my lungs. At the emergency, when they sent me to the ICU, I heard the words fatal. I heard the words catastrophic. I was in total denial at that point. The first, and I do believe that the denial got me through, was a big part of my defense mechanism. The first medicine that they tried for as a blood thinner, my body rejected. So they inserted a filter in me to catch the blood clots to prevent any further going up. That worked to a certain point. Then they found a second round Xarelto blood thinner that did work. But it took months for the blood clots to dissolve, and I didn't have the IVC filter removed, which was temporary, until June of this year. I have been cancer-free since August. My MRIs and scans have showed no evidence of cancer. But what have I done in addition to that? I am part of 3 support groups, right? I find joy. I wake up with gratitude every day. Friends, family. I exercise. I eat well. I can eat better. There's always a work in progress. By far, I'm not perfect, but it's, I incorporate everything a little bit. With the rehab, with this latest surgery that I had last year, it did affect my right side, and it did affect my mobility. I had recently, I had to go through, I said rehab, but I also did physical therapy at the end, when I came back home. I recently have taken up, I completed a coach certification in breathing, which a lot of it was based on yoga breathing, the pranayama that was mentioned earlier. And right now I'm in an intense yoga program where it's incorporating, I did it more for the physical aspect of it, but it's a lot more than that. The breathing, the meditation, the exercises is proving to be so beneficial. The picture up above on the right, not directly above, but on the right side, that's when second to the last day of physical, when I was in rehab, right? You can see from the steroid use, just from radiation, more from the steroids that really gave me, made me puffy, that moon face that they call. But they did an awesome job. I had a great team there of physical therapists, right? And on the left, the top left is me in January, celebrating my 60th birthday, which, I didn't know if I'd reach that. That's my daughter on the right. The week prior to that party, I was able to go to her 40th birthday party. And that's a picture with my family and a very close friend who's like family, family are friends, friends are family. a combination of all, but as you see in all three pictures, I am smiling. As part of the, what keeps me going is a positive attitude and finding joy, gratitude, and incorporating all the lifestyle changes that I've had to incorporate and bring into my life, and which I plan to continue. I want to show one more thing, and I don't know if you can see it here. It's a medallion. I don't know if you can read it. I received that at my 60th birthday party from a good friend of mine who I saw was in attendance tonight. She gave me this that says, "Miracles happen." And miracles happen, and miracles can happen. You what do you call it? Luck, timing, medicine, lifestyle changes, everything that we're talking about can result in small miracles. They don't have to be big miracles, but little miracles. Every day I wake up is a miracle,
We're all getting goosebumps as we are hearing your story. Thank you for sharing that, and thank you for being vulnerable. Sometimes when you tell your story, you go back and relive those memories, but you are here
Yes.
to serve, to add this value, and to share with us what really worked for you. And can anybody believe that he is 60 years old? Like, it's so hard to believe. So, Adolfo, thank you so much. We really appreciate everything that you shared.
You're welcome. My pleasure to be here. Thanks.
Yeah, thank you. This question is from Mohan. How effective are liquid biopsy tests for early detection of cancer?
Right now, what we are doing is not for early detection. Most of the liquid biopsies are being done in the metastatic setting, but there are tests actually being developed, specifically breast cancer. There are liquid biopsies are being proposed right now, looking at circulating tumor cells for early detection. The challenge right now is many cancers do not spill cells in the blood to be able to be detected by the liquid biopsy. So, a lot more research is happening right now, but most of the liquid biopsy work is going on in the metastatic setting, figuring out new mutations that may be happening in cancer cells that may make us, use different type of therapies, specifically in lung cancer, mutational changes in the kidney cancers, again, actionable mutations. That's where the liquid biopsies are being used at this time.